Hello people. So we are looking at the top priority questions in gynecology. We have completed this much we have completed. Now let us look at this lower half here. Semen analysis. Semen analysis basically sperms, right? So you want to check what and all will you check about semen. So you should check the volume. Okay, volume should be greater than 2 ml normally. Right? Are you able to understand where we are here? Volume should be greater than 2 ml. pH should be around 7.2 to 8. Okay, that is what? That means slightly alkaline, right? Slightly alkaline. Sperm concentration is greater than 20 million per ml. So totally how much should be there for 2 ml? 40 ml. Okay, 40 million. Then the morphology, at least 30% sperms should have normal morphology. Please, are you understanding where we are, or it's too small for you to see? Here. Look at this. The morphology at least greater than 30% sperms with normal morphology. Are you understanding, guys? Normal morphology, how much? At least 30% should have. Vitality, at least 75% should be alive. White blood cells should be less, otherwise it's an infection. Then you should see that how is the motility. Motility should be rapid, like something like that you can write. Then anti-globulin reaction, that's some that you can leave, it's quite complicated. Then coming to the biochemical variables, look at this, fructose. Fructose will be there in semen, zinc will be there, acid phosphatase will be there, citric acid will be there, alpha glucosidase and carnitine will be there. Can you see all this, people? And everything should be greater than. Okay, see, what and all should be there? Fructose, zinc, acid phosphatase, citric acid, alpha glucosidase, carnitine. Can you say all this? This is very difficult for you to say. Try. Fructose in semen, yes. Fructose in semen, what and all will be there? Fructose, zinc, carnitine, some alpha glucosidase came, is it? Then I forgot something. No, wait, we are looking at this, but what is the chart here? Acid phosphatase, yeah, citric acid, alpha glucosidase, carnitine, okay. So all this you should know. If you want, you can look at some extra details here, which is prostate marker, which is epididymis marker, which is seminal vesicle marker, all that you can see. We didn't study so much in detail. Anyways, dermoid cyst. Now, dermoid cyst is nothing but benign cystic teratoma. So this is very common question in the exam. So in surgery exam also. So this one you can see, this is the dermoid cyst. Inside it has teeth and hair. No, it's a teratoma. So basically it has all 3 layers of germ cell. So not just skin. So dermoid cyst itself is a misnomer. It should be called as benign cystic teratoma. Okay, it's a teratoma. So it can be either benign or malignant, right? So this is very important. The complication with this is it can lead to torsion of the ovary. So that's what you should understand. This is the main point that you will write, and then you will anyways excise it. Okay. So in the naked eye appearance, how is it? Cut section, they're saying Rokitansky protuberance. Okay. This is something that you should know. Rokitansky protuberance. Sometimes these can have, this teratoma can become specialized. Like it can start secreting thyroid hormone. That time it will be called as struma ovari, right? So for the cyst, you can do cystectomy or you can remove the ovary itself if required. Dysmenorrhea. What is dysmenorrhea? So painful menstruation. So if it is starting few hours just before the menstruation and then it will last during the menstruation and go away, this is called as primary dysmenorrhea. This is what I had, spasmodic, right? Mostly this only people will have. Secondary dysmenorrhea means it comes before the period, and then once the period comes, it will get relieved. So this is a very strange thing. It will come before the period. And once the period starts, it will actually stop. This is secondary dysmenorrhea congestive. This is usually pathological. Okay, that means there is some pathological problem. It can be some cervical stenosis. So the narrowing is it. Chronic pelvic inflammation. So some infection they are saying, right? Stenosis of the cervix. So these are all the causes. Okay. Then there can be a endometriosis, which is so painful that we already told you. Some adhesions, adenomyosis, uterine fibroid, polyp. So all these are what? Pathological, right? You understood. There is some IUCD in utero. So they have put an IUCD because of which there is pain. So the uterus will try to put this IUCD out. It will try to throw away the IUCD. Are you there, people, with us? What are we looking at? Dysmenorrhea. Also, it could be because of some Mullerian malformation. So for spasmodic pain, you can give some mefenamic acid, prostaglandin synthase inhibitor, right? Then for congestive, you'll have to find the cause and fix it, okay? Now let us look at secondary amenorrhea. Secondary amenorrhea means these people have had periods before, now it has stopped. That means to what are you trying to say? That means they could be pregnant, okay? The first thing you'll rule out is pregnancy. Then you'll also check if there is some thyroid issue. Then you will check thyroid, hypothyroidism, etc. You will check. Okay, then thyroid levels you will check. Then is it a pituitary cause? You can check the sella turcica where the pituitary sits. Prolactin levels also you will have to check, because sometimes if prolactin level is high, then they can go into amenorrhea, just like a lactational amenorrhea kind of a state. But probably they are not lactating, but the prolactin levels are high. So you'll have to check all this. So what will you check for a person who comes with secondary amenorrhea? That means she has she's not menstruating. Okay, so what will you check? First check if she's pregnant. Then if she's not pregnant, then you can check prolactin level and thyroid level. Okay, if that and all is normal, again you can check for pituitary. I think that is kind of a last stage kind of a thing. Normal, what they will do, they'll give a progesterone challenge test. Okay, so they will give progesterone, and then once the progesterone is withdrawn, then the person will bleed. So that means to say everything is fine, right? That means to say it could be probably a PCOS case. This person is not ovulating. That's what it means. Okay. Then if progesterone challenges, she's not bleeding. Okay. Then she's not bleeding. That means what to say? Progesterone is not the cause. Then maybe estrogen is less. So then they will throw an estrogen progesterone challenge test. Okay. So estrogen will allow the endometrium to grow. Then once endometrium grows and it will shed, then again endometrium is fine. Once the bleeding occurs, then again you check for LH and FSH levels and check whether it is a hypothalamic or pituitary dysfunction. Okay. Now if there is no bleeding, that means to say that endometrium is not functioning properly. So you'll have to do a hysteroscopy and rule out synechiae. So all this we have covered in the secondary amenorrhea video. Just let me tell you what I told you so far. So you will give progesterone to the person. If she bleeds, then well and good enough. So probably it's a PCOS case. If she does not bleed after progesterone, that means to say that there is some problem with the endometrium. That's what they're thinking. They'll give estrogen progesterone challenge test. That time she has to bleed. If she bleeds, that means to say that the endometrium is still receptive, and then we'll have to check what the cause is. LH, FSH and all you will check, and check whether it's pituitary or in some cause. If she does not bleed even after estrogen and estrogen progesterone challenges, that means there's some problem with the endometrium. So you'll have to go and check the hysteroscopy. You'll have to go and do and check the endometrium, right? That's what they're trying to say here, right? Yeah, if she doesn't bleed after this estrogen progesterone challenge test, if she does not bleed, you'll do hysteroscopy and rule out synechiae. That is Asherman syndrome. We will rule out. Okay. So if she has bled after this estrogen progesterone challenge test, that means to say check why estrogen is less in this person, whether FSH, LH is normal, all that you will check. This is all about secondary amenorrhea. Now let's go back to our beautiful top priority questions. Last two in this. Okay. Stress incontinence. Stress incontinence means urinary incontinence, right? So what do you know about incontinence? So how, what is the nerves to pee and all that and all you should know. This is more like anatomy and physiology. Now stress incontinence means, normally, now how do you maintain continence? That means normally how you will control your urine. See what will happen when the abdominal pressure increases, there is kinking, there is a bending of this urethra. Okay, so it will kind of close. Okay, and also the sphincter will close because of the abdominal pressure. This is how we maintain continence, and also because of our nerves which helps us and the bladder which relaxes. A lot of reasons are there for urinary continence. Now incontinence. Incontinence means what? Involuntary loss of urine which is causing some inconvenience to the person. Okay. So you have stress incontinence and other types of incontinence. Look at this. So stress incontinence means it happens because of stress. That means only when the person coughs or sneezes, right? That time they will pee a little, like when they laugh loudly also. This used to happen for me also after I have delivered the baby. Now it is not happening. Anyway, so basically here there will be funneling of the proximal urethra. So what will happen? This abdominal pressure which was helping the urethra kink and the sphincter to close. Now because of the funneling, let me show you the image. See here they have shown you the funneling. So what is happening? This pressure is not able to, this has kind of come down. See earlier this pressure was holding this sphincter, right? Closing the sphincter, everything. But here this pressure is not able to close the sphincter. So this is that funneling. So this is why stress incontinence occurs. So there are a lot of causes for this stress incontinence. So anyways, for these people, you will check if there is some bladder neck funneling, you will check, and then check that there is no UTI or something, because sometimes UTI can cause this type of incontinence. See, grade 1 only I had incontinence with cough and sneeze. With mild exercise, maybe little I had. Even with change in posture, this I never had. So this is grade 3, okay. So avoid repeated childbirth, they are saying. This is one place where they are telling that don't have many children. That's nice, right? The first time I saw this. Otherwise, everywhere they'll say that have children, avoid so many problems, okay. How will you treat stress incontinence? You'll have to do some pelvic floor muscles training. You'll have to do Kegel exercise. So then you'll have to have some bladder neck support prosthesis if required, vaginal cone, electrical stimulation of the nerves which help in the incontinence, so in the continence. Obesity, if it's there, you can treat. Then you can give estrogen for postmenopausal. Then you can give imipramine, same thing what they give for nocturnal enuresis they had told. But imipramine is not used there anymore. And then para-urethral implant injection. Collagen they will put into the urethra so that it will close, is it? A little. So that it doesn't give up and open up and pee. Okay, so into the urethra they are putting some collagen. So these are the treatment for stress incontinence. Stress incontinence has so many surgeries. You have the retropubic, that is a Burch surgery. Mid-urethral tape is there, sling is there. Okay, neck suspension, endoscopic bladder neck suspension, bulking agents. So bulking agents means what you will do, collagen, Teflon. Okay. So here they are trying to show you the Burch operation. Colpo suspension, then they are showing you MMK procedure, is it? Oh, everything is in the same diagram. This is the TVT procedure where they are using some tape. You can see here, this is the bladder and this is the urethra. They are holding that urethra through a tape and they are kind of putting the tape here. Tension free. The tape is there tension free under the urethra. See here again they are putting so many tapes. TVT, TOT, obturator, is it? Transobturator placement, okay. Then here what is they showing? Transobturator tape, same thing. TVT, TOT. And people, there are other types of incontinence also. You have urge incontinence which is sensory. Then you have the urge incontinence which is motor, that is motor do they call it? Detrusor instability, okay. Overactivity of the bladder, that also is there. OAB, overactive bladder, okay. So urge incontinence sensory is because of infection, UTI, okay. And detrusor overactivity, as the name suggests, it is because of the overactivity of the detrusor muscle. Now let us look at the last one. Yay people, come on, you have finished a lot. So now let us look at the last one people. What is this? High risk for choriocarcinoma. That means placental tumor has become cancer. So when will this happen? This is a trophoblastic disease. That means placenta. When will placenta form? Only if the person becomes pregnant. So either normal pregnancy or abortion or a vesicular mole. That is a wrong pregnancy, kind of a wrong fertilization. So wrong fertilization will lead to a molar pregnancy. That can be a partial mole or a complete mole. Complete mole has more chances of becoming a carcinoma. So it is all placenta which is becoming carcinoma. So please understand, the person has to get pregnant, then only they can become they can get placental tumor and carcinoma. So you have choriocarcinoma. So basically if a normal pregnancy turns into a choriocarcinoma, that has worse prognosis, and in choriocarcinoma there is no villi seen, okay. So you can give chemotherapy, there will be good prognosis, or you can just do a hysterectomy. So here they have shown you choriocarcinoma, okay. Necrosis and all that, is it? Bulky hemorrhagic mass, okay. See, they have not asked you all this about partial mole, complete mole. They can ask, but what they are asking here is who is at high risk for choriocarcinoma. This is what they are asking you to write. If the HCG level is greater than 1 lakh, okay, milli international units per ml, if the uterus size is greater than 20 weeks, if the patient's age is greater than 40, if she has had more than 3 children, if she has had a previous history of molar pregnancy, if there is theca leucan cyst, that is, I think, complete mole. That's what it tries to say, right? So this is what is going to be high risk for choriocarcinoma. Try to recollect and say what are the high risk for choriocarcinoma. Come on, say. HCG level greater than 1 lakh, very good. Milli international unit, very good. Then patient age greater than 40, yes, very good. If she has had more than 3 children, very good. Then if she has had theca leucan cyst, yes, very good. If she has had a previous history of molar pregnancy, very good. Then I forgot one more. Yeah, tell. Uterus size greater than 20 weeks, okay. Excellent people. Now we have to move on to this specific terms in gynecology. So people, why are we looking at these specific terms in gynecology? See, just go back here to the top priority questions, okay? If somebody asks vaginal infection, no, you will write a lot. Sure, you will write a lot. If somebody asks you about semen analysis, something you will write because you know what it is, right? But if somebody asks you some question like this one, RU 486, you're like, what the hell is RU 486? Because you didn't look at what this is. So even if you know what it is, something you'll be able to write, okay? So you just understand this RU 486 is nothing but mifepristone that is used in MTP, right? Medical termination of pregnancy. Mifepristone. What is this? It is blocking the progesterone receptors, right? And how much they give? 200 microgram. No. For MTP they'll give how much? 200 milligram, correct? Let's look at this dose. Very, very important is this. Look, open the unwanted kit and see how much they'll give. So here you can look, mifepristone 200 mg, okay. Then what else you'll give with it? Misoprostol 200 microgram, total 800 microgram, okay. So this is what you have to remember. Then Whiff test you have already seen in bacterial vaginosis, is it? Yeah, this is basically whiff test. You will put KOH on that discharge and then you will get foul smell. Then that is what is whiff test. So basically you have to explain here Amsel's criteria, right? Amsel's criteria is where you will have clue cells, then whiff test positive. Then what else you will see in Amsel's criteria? Look at this. Amsel's 4 diagnostic criteria: vaginal discharge, vaginal pH greater than 4.5, pH is more, remember, whiff test positive, presence of clue cells, that is that stippled epithelial cells, okay. So this is Amsel's 4 diagnostic criteria. Discharge should be there, the pH of the vagina should be more, whiff test should be positive, clue cells should be there, okay. Here you have the clue cells. Clue cells. Earlier they thought it is caused by Gardnerella vaginalis, but now they think it is because of some bacteria, bacteroids, Peptococcus, Mycoplasma, etc. Okay. So there is a marked decrease in lactobacilli. There is a decrease in lactobacilli, remember, which is actually good, right? So that is decreased. Fishy smell. Then coming to Mittelschmerz pain, because this is nothing but ovulatory pain, okay. So that means ovulatory pain means when will it happen? 14th day around, right? So you can say that this pain will come only for people who have ovulation. So they'll have pain in the hypogastrium or in the iliac fossa, okay? No vomiting will be there with this. Metropathia hemorrhagica is nothing but DUB, okay? It is also called as hyperplasia, right? Glandular hyperplasia. Go back to that and check that. Where is that PPT? So this we saw under DUB. This is myohyperplasia, perimenopausal women. So this is metropathia hemorrhagica or cystic glandular hyperplasia or Schroeder's disease. You can see how the endometrium is thick, congested, microscopic. You can see the glands are all small, others are large, giving it a Swiss cheese appearance. There can be areas of necrosis. So basically these people, what will happen? They will have anovulation. They'll have, so as it is anovulatory, they'll have painless cycles, right? So they'll have abdominal uterine bleeding, okay. So this you will see in perimenopausal women, remember, okay. So treated very similar to DUB. So you will have to rule out malignancy always, and then you can give mefenamic acid if there is no pain, but there is no pain here, so no need to give. You can give progesterone and regularize the cycles, endometrial ablation, resection, hysterectomy, okay. This is the treatment. Good progress, guys. Okay, now we'll move on. Okay, just 3 more left. Asherman syndrome is nothing but cynic adhesions. Why does this happen? Because of some activity that happened within the uterus, some curettage, etc. So this is because of adhesion. Okay. This will lead to secondary amenorrhea also. It can lead to. Then Fern test or spin bucket test. Fern test is different, spin bucket is different. Both of these are tests for ovulation. The cervical mucus, you can see here, Fern pattern is there before ovulation. Okay, this is Fern test. Spin bucket is about the consistency of the mucosa, how long you can pull it, etc. We'll show you a better table weight. After ovulation, the elasticity of the mucus is decreased. Okay, after ovulation, the elasticity of the mucus is decreased. So basically, tests for ovulation, you can learn, people. There are many tests for ovulation, basal body temperature, then a lot of enzymes you can check, or hormones. Yeah, this is the table I was talking about. See, this is basal body temperature, how it will be, cervical mucus, threadability, Fern pattern, then endometrial biopsy you can do to find out at which level the endometrium is it secretory or what is it. Vaginal cytology you can do, what types of cells will be there. You can check the progesterone, LH you can check. Then you can do the transvaginal sonography, laparoscopy also you can do, okay, to check if she has ovulated. A sonography will indicate to you the follicle measurements, etc. So now let's look at Turner syndrome, people. Chromosome abnormality, one X chromosome will be missing. So these people, how will they be? 45X, this is what their karyotype will be. Short stature, constriction of aorta, poor breast development, white space nipple, no menstruation. That means primary amenorrhea they can have. Then they can have a fold of skin in the neck, is it? Low hairline, right? Then, so here again one more diagram is there where they are trying to show pigmented navi, peripheral lymphedema at birth, streak ovaries, infertility, cubitus valgus, is it? Yeah. So they have some congenital heart disease, etc. Okay. What can you do for these people? It's chromosome abnormality. Okay. So you have completed all the specific terms in gynecology also. So you are all set for your gynecology exam. Do well, people. Keep revising, and whatever you have learned, you revise. Don't go to learn new things at the last minute. How to pass obstetrics and gynecology, we have separate video. Look at that also. That will give you a lot of tips.